So I'm just going to touch on a few things. I'm not going to go into a lot of detail because I think, let me just, because I think, as I said, I want to spend most of the time with questions. But I'll first talk about what these viruses are. What's a coronavirus and what's the deal with this particular one? Say a bit about who's getting infected, where and why, how we diagnose it. Talk a little bit about what happens to people who get infected. And then say just a few words about where I think we're headed and what we can do about it, particularly related to some treatments and vaccines. And then let's open it up for specific questions after that. Does that sound okay?
Yeah, that's fine. And for those of you who want, we'll see how it works out, but feel free to unmute yourself and ask the question directly. If it gets to be too busy, then we'll go to the chat for questions.
Sure. So what are coronaviruses? The word corona, for those of you who are Latin and Greek scholars will know, means crown in Latin and wreath in Greek. And that's to describe what it looks like under the electron microscope pictures shown here. It's got these spikes on the outside. There are thousands of coronavirus species out there, at least 1,300 that we've already characterized and identified. And they're common viruses that are seen in all sorts of animals, particularly bats, but lots of other animals and humans as well. We'll talk about the viruses that we know about, the coronaviruses that affect humans. So these coronaviruses have been around as long as we have, and they've been mutating and jumping between different animals, from other animals to humans, for hundreds of years we know of. We have evidence from hundreds of years ago that some of these coronaviruses were causing common cold-like symptoms hundreds of years ago. So the corona, the spike protein on the outside that you see in the bottom picture, is a protein that sticks to the receptors on cells that we have in our respiratory tract. So cells in our nose and throat and our lungs have receptors, and the spike protein can stick right onto the outside of those cells, and that's what it uses to help get inside of our cells in our respiratory tract and cause the symptoms and infections that we're dealing with today. So you probably read a lot about different terms, and it gets confusing sometimes when you read the different reports about what's what. So there, you'll see something called the SARS-CoV-2. Well, that stands for Severe Acute Respiratory Syndrome, Coronavirus 2. That's the name of the virus. So SARS-CoV-2 is what we actually call the virus. You'll see something called COVID, which is really a short acronym for coronavirus disease. So COVID is the disease that's caused by the virus SARS-CoV-2. And when you see COVID-19, that's the disease caused by this virus, because it's called COVID-19 because it started in 2019. So this COVID-19 is the name of the disease caused by the SARS-CoV-2 virus. So there are at least 7 coronaviruses that cause diseases in humans that we already know about. But you don't have to, maybe we'll have a quiz later to see if you can memorize all these different species and strains. But all you really need to know is that we have at least 4 of these we've known about for a long time, cause the common cold every year. These are very, very common in humans, have been for years, don't usually give us more than a sniffle. And most of us have been infected with these. And an important thing to keep in mind is that many of us have been infected multiple times by the same 4 coronaviruses. We've had common colds over and over again. And sometimes it's the same virus that we had 2 or 3 years earlier. And we'll talk about that when we talk about what immunity means to this virus. There have now been 3 serious pneumonias caused by coronaviruses, which are much, much more serious. And they're listed on the right side of that slide. And all 3 of these outbreaks have occurred in the last 20 years. So we've had all these other 4 coronaviruses on the left in humans for hundreds of years, and the really nasty, serious ones on the right, including the current one. All 3 of them have occurred in the last 20 years. And so in 2003, we had what was called the original SARS epidemic. So that was an epidemic that started in China as well and spread to Hong Kong and around the world. And over 9 months, we had over 8,000 cases and over 700, close to 800 deaths in 32 countries. And then it went away. So this was a really nasty coronavirus that started in bats. It probably jumped between bats and another animal called a civet cat. We think that because the virus that caused human disease genetically looks very, very similar to the same virus, to a similar virus in bats and civet cats. But over 9 months, this spread around the world, and it was it wasn't highly infectious, but because it only spread to about 8,000 cases, but it was dangerous. It killed 10% of the people that had it. And then in 2012, we had another coronavirus called MERS. MERS stands for Middle Eastern Respiratory Syndrome. And that began in the Middle East, Saudi Arabia, and other countries in the region. We think the source came from bats and probably camels. This coronavirus also caused a lot of deaths. It actually was even more dangerous than the first SARS because it killed a third, 35% of the people that got this disease died. And this one actually caused about 842 deaths over 8 years. And this, actually, we're still finding cases today of this particular MERS virus in the Middle East. I'm sorry if I got background noise. I can hear some noise in the background. I hope I'm still audible. So here we are now in 2019, 2020 with this. Now this is an old slide. I didn't update the slide from a couple of weeks ago, and I'll show the new data. But we've now had in the United States more than close to 60,000 deaths in less than 3 months. So compare this epidemic to what we had with the other coronaviruses. You can see how much more serious this one is. The good news about the earlier two coronaviruses is that they were very deadly, but they were not very infectious. So they didn't spread to millions of people. We now have over 2 million people in the world infected with this new virus in less than 6 months. So it's much, much, much more infectious than the other two. So I wanted to talk a little bit about, we see lots of statistics, numbers of people who are sick, numbers of people who have died, etc. I'm sorry, I think, is that too noisy in the background? I can move to a different
No, it's not bad. We can
spot.
still hear you fine. Yeah.
So if you read the current number of cases that were reported in the last 24 hours, if you read statistics from New York or from your own town or your own state, and it says in the last 24 hours we've had X number of new cases, it's important to keep in mind that the people that were cases today were actually infected over a week ago. So what you're measuring today in cases are people who are sick, who have symptoms. And it takes about a week from when you're infected to when you develop symptoms. That's called the incubation period, shown down here in this slide. So new cases reported in the last 24 hours reflect what was happening a week ago. Now, what about the number of people that died in the last 24 hours? We're reporting how many people died in different places in the last day. It's important to remember the people that are dying today in the emergency rooms and in the ICUs were people that were infected on average 3 weeks ago. So we're looking at a snapshot of data today that reflects people that were infected 1 to 3 weeks ago. So we're a little bit, keep that in mind when you look at whether things are going up or down, because we're really not getting a snapshot of what's happening today. We're looking at a sort of a retrospective picture. And the reason why it takes 3 weeks for the mortality statistics is because people get sick in about a week, and they either get better, most of them do, 80% of them do, or they don't get better in about 20%, and they end up in the hospital. And usually around day 10 to 12, if they're going to get sick, they get very sick, and they end up in the ICU, and they're on a ventilator, and they remain on a ventilator for another week or two, and then if they either survive or they don't. And that's why death data reflects something that happened 3 weeks ago. Does that make sense? let's see. There we go. So these are the data from yesterday, I believe. Looking, this is from the on one of many data sets that you can look at. It shows the number of cases, and I like to look at data like this. It shows the number of cases reported, you know, in the last week or the last few days, and you can see that this was. I don't know if you can see my pointer or not, but here on the left side in gray is the epidemic from China in gray, which started back at the end of you know, the end of January, end of December, early January, and then peaked, and then was basically gone by, you know, mid-February, late February. There's still a few cases, but look at the rest of the world. The rest of the world, and particularly in Europe and America, have predominated, and we'll talk more about that in a moment. So this is another way to look at what's happening. This is the cumulative number of confirmed cases as a percentage of the population. So the darker the color, the higher percentage of the population in that country has diagnosis of COVID. And you can see that Europe, in particular, Spain and Italy, and now the United States have the highest number of cases, but also the highest percentage of the population with infection as of today. And this has been a moving target. If you take a snapshot like this, if you'd taken this data from a month ago, it would have been all in China. It would have been dark. But now it's shifted to Europe and the United States. And it's shifting now, again, to other parts of the world, which perhaps we can talk about as well in a minute. I wanted to say a word about, you know, how we diagnose it, because there's lots of stuff in the news about different kinds of testing, and should we be doing an antibody test or should we be doing a PCR test? So there are really just two ways right now to diagnose this infection. One is what we've shown at the top here. There's some just examples, which is a PCR test. So a PCR test is simply where you take a swab. You've probably seen pictures of people driving into tents where somebody reaches through the car window and swabs their nose with a cotton swab. And they stick it into a vial, and that vial goes to a laboratory, and that's tested. And that's the test that's used is called a PCR test. And so the test detects the virus. It detects pieces of the virus. It doesn't detect the live virus. It detects what's called the nucleic acid or the RNA of the virus. And so a PCR test is a swab test that's used to detect the presence of the virus in your respiratory secretions, your nose, your throat, or your sputum. And there are different ways of doing the test illustrated at the top. But some of these tests are relatively fast, but they generally, and they're really pretty good, but they're often labor intensive. They require laboratory equipment and laboratory people to process these specimens. And sometimes if there's not enough tests available, as we face in lots of parts of the United States, it can take up to 4 days to get the results. Not because the test itself takes that long, but because they're backed up in these laboratories, or they don't have enough swabs, or they don't have enough reagents to run the test, so things get backed up. The other test that's being looked at more recently is the antibody test. And those of you who've done your AP biology would know that an antibody is really a protein in the blood that our bodies make when we're infected with any kind of infection, particularly a virus. And so the antibody is a blood test, and it detects whether or not a person has been exposed or, we hope, immune to the virus. So it doesn't detect the virus itself. It doesn't tell you whether somebody's infectious to other people. That's the PCR test is a better test for that, but it tells you whether someone might have been exposed. What we don't know is whether an antibody, we know that an antibody test probably means exposure. What we don't know is whether a positive antibody test means you're immune or you're protected from the virus, because we don't yet know which antibodies are the right antibodies to protect us. We know we can detect antibodies, but we don't know if those antibodies are really good and protect us in the future. And I can certainly answer more questions about that later. But I just wanted to give you an overview. So what happens to people that get infected? Depends how old you are. It depends on whether you have underlying conditions. This is one of the first studies from China, and this kind of data is similar to what we see all over the world. In red shows you the percentage of people who died. based on their age. And you can see if you're young and you get this infection, the risk of death is relatively low. And the older you are, the risk can get very, very, very high. And that's been confirmed, not just in China, but all over Europe and now here in the United States. Another way to look at this is to compare what happens with regular flu on the left and COVID on the right. So this is the same age groups, and it compares the higher the red bar, the more deadly it is. And you can see that for every age group, even for the younger age groups, the risk of death from this infection is 5 to 10 times higher for COVID than it is for the regular flu. So when people tell you that this is just like a regular flu, this is not at all like a regular flu. This is much, even for young people, this is a much more deadly infection. I mean, and we'll talk maybe more about this in a minute, if COVID was just a bad flu, we wouldn't be so worried about it. We wouldn't be quarantining. The reason we're quarantining is because this is a deadly disease for a significant percentage of the population. So where are we headed and what can we do about it? Many of you have probably seen the Hopkins website that's tracking this sort of thing. And there are others out there. I just took a snapshot this afternoon. So we're up to over 2.6 million confirmed cases. This is people who have a positive test. And these are data reported in from all over the world. But remember, not everybody who has this disease is getting tested. So we know this is an underestimation. But if you look down in the right corner in the yellow graph, you can see that globally, it looks like things are peaking and plateauing at the moment. We hope that continues, but I think we have to wait and see. This is the global statistics. We'll have to wait and see what happens in India and sub-Saharan Africa and Latin America, because we could see another peak as things progress in some of these other parts of the world. Here's the United States, just for comparison. We have almost 1 million people confirmed infected. And again, it looks like it's plateauing. We hope that that's true. But as the epidemic moves to other parts, I mean, the United States is a big country. And so it's almost like separate countries within a country, like Europe. So we don't know exactly what's going to happen, for example, in Florida or in Texas, as things move into those communities. But we're certainly seeing some evidence things are beginning to slow down a bit, but still a very significant number of people getting sick and ending up in the hospital still today in the United States. So I thought I'd spend a minute just, I showed you the data that China was able to jump on this and seem to control it very, very quickly. So what did they do that might have helped? Well, what they did, I'm not sure we can replicate in most societies in the world. They just locked that place down. I mean, they had, by the end of December, the first cases. By the end of January, they basically locked down. They did what we're doing now: social distancing, quarantining at home, traffic ban, within a month. Now, they were much earlier than we were in the United States and Europe in implementing that first step. But that wasn't enough. They realized pretty quickly that slowed things down. It flattened the curve, but it was not going to stop this thing. So they went to another phase, which was they called centralized quarantine. And it had and I talked to some of the docs in Wuhan a couple of weeks ago, just so I could better understand what they did. And it's amazing. It's really incredible what they were able to do. Again, I don't think we could do that here. But they basically went door to door in Wuhan, and they tested and screened everybody in their homes. And if they had a symptom, they took them out of their homes and put them in a quarantine facility, a hospital, if they were sick, they were in a hospital. If they were negative and lived with somebody that was positive, they also went to a quarantine facility. They pulled them out of their homes. They put the kids in one place, the parents in another place. So the close contacts of confirmed patients were sent to hotels and college dorms to isolate together. The health workers, doctors, and the nurses also lived in separate hotels and facilities, so they wouldn't be spreading the infection to their own family members. And they arranged local delivery of food. They provided special transportation for millions of people in this district. It was just incredible what they did, and it had the effect that it seemed to control the epidemic there. Now, similar approaches have been done in other countries, for example, in South Korea, but not with the such a strong mandatory, government imposed system. But the community was very, very supportive, and they went out very fast and did testing in places like South Korea and Singapore. So there are examples of models like this in other countries that essentially were able to achieve the same results. But it's all about starting early, shutting down with physical distancing and quarantining, lots of testing, screening of contacts, and trying to prevent people from spreading the infection as fast as we can. So let me finish with a couple words about what we're hoping we can do about this. I think if we can develop some treatments to make this disease less deadly, it'll change the game. I think if we weren't so afraid of this infection killing our older relatives and ourselves, we had treatments to prevent that kind of serious illness or death, it could be a game changer. So in the next couple of months, next month or two, we're going to have some of the first data on some drugs, in particular drug called remdesivir, which was developed actually originally to treat Ebola, which seems to have some benefit in animal models. We don't know yet whether it's going to work in humans, but there's studies going on right now, including at Hopkins, to compare remdesivir to placebo to see if those who got remdesivir do better. And if we can find a treatment that prevents people from ending up in a respirator, on a respirator, or in an intensive care unit, that could be very helpful. Another example of a treatment is called the serum treatment, where you take blood samples from people that have recovered, you take the antibodies from their blood and you give them to sick people and see if you can make them better. And so those studies are ongoing now, and actually we should have some preliminary information about that in the next month or two. And I'm hopeful, I'm optimistic that we'll see some benefit there, because that could be a big help. There are many other drugs in development that are going to take more months or years, but I think we're going to have I hope some good news in the next month or two about some of these earlier treatments, the remdesivir in particular, and serum, and convalescent serum treatments. Finally, vaccines. I've been involved in HIV vaccine development, and I've also been working with vaccine developers in India on some of their vaccines over the years. And so I have a pretty good idea of how long it takes to develop a vaccine. I can tell you that this current effort to develop a COVID vaccine is working at world record speed. I think we could have a vaccine in the next 12 to 18 months, and that would be by far a world record for any vaccine. So the first human studies actually started a few weeks ago in the United States, in Europe, and in China, and in Japan and Korea and other places. It usually takes a couple of months, 2 to 3 months, to make sure that if you inject a certain number of people with the new vaccine, that it's safe, because you don't want to give a vaccine to people that's not safe. And you also want to make sure that the vaccine stimulates the immune system and basically tricks our immune system to thinking we have COVID, so we develop immunity and make an antibody or other response to the vaccine. Because if the vaccine doesn't stimulate that in people, it's not likely to work. So that kind of first safety, what we call immunogenicity studies, take a couple of months, 2 to 3 months. So we should have some data on that probably, let's see, it's April now. I'm thinking probably late June, early July. And by July, if everything goes well, we'll start what are called the efficacy studies, where you give large groups of people. Some get a vaccine, some get a placebo shot. Nobody knows which is which. And then you follow these people to see how many of them get infected in each group. And the hope is that those that got the vaccine have fewer infections than those that got the placebo. And that would be great, because then we would know that the vaccine actually has some benefit. Those kind of efficacy studies take up to a year, because you have to follow people for a long period of time and enroll lots of people to determine whether the vaccine works. And if it works, then it takes another 3 to 12 months to scale up manufacturing production. So we're talking at least 12 to 18 months minimum before we can actually make a vaccine that we could share with people or even offer to people. But there are many, many companies working with many different versions of this of a vaccine to try to get there at world record speed. I'm going to end with my comments with just a story that I think illustrates why it's so important, particularly for all of us, to maintain social distancing and to avoid making ourselves a vector unintentionally for this virus, because it's extremely infectious. So in this picture is a family portrait of a Italian-American family up in New Jersey from last month. And those of you, I'm not Italian-American, I'm Irish-American, but we have similar traditions in our family where the families get together once a week often, or on regular occasions for dinner with the extended family. And they did this every week at their grandmother's house up in Jersey. And then that was on a Tuesday. And by the end of that week, a lot of the people in this picture, 4 of them died from COVID, including the grandmother. And 6 other family members, including some of the younger people in the family, were very sick and in the hospital. Some of the grandchildren ended up in the hospital. It basically wiped out this family from within a week to 2 weeks. This whole family was just devastated. And there's so many examples of this. I was on a call this week with friends of mine in India, and a friend of mine runs a hospital in a rural community in India, and they had their first 27 cases last week that came into this hospital in this very rural community. 26 of the 27 were from the same family. And that was the first exposure they had to in that community. And now, of course, it's just taking off. And you're going to hear these kind of episodes. And that's what, for example, why so many nursing homes are having outbreaks, or homeless shelters, people that live in close communities or in close contact with each other. And if any of people who are in this close-knit community then move to another household or to another situation, they're just going to spread the virus, and that's how it rockets up the way it's done in Europe and the United States. So I think I'll just end with just reminding us all we have to all practice very strict. Let's not call it social distancing anymore. Let's call it physical distancing. I think we can still be social, and I certainly don't have to tell your generation how to be social on media, but we should be physically distancing and stay home, at least 6 feet away from all neighbors, friends, and relatives you don't live with. Wash your hands, sing happy birthday so you do it for 20 seconds. And remember that very few of us are really essential. There are essential people that are keeping us fed, keeping us cared for and safe, but all others should stay home and telework if they can. And I always tell my friends and family, that means no play dates, parties, family reunions. I'm sorry. This is a desperately important situation. We have to do what we can to prevent this from spreading. So I think that's my last slide, and I hope it leaves us enough time. I'm just going to stop.
Hi, my name is John V. I'm from St. Louis, Missouri. So I was reading, and I heard that certain countries, policies are like quite reliant on the development of herd immunity. So to what degree do you think like we as a society should shape our policies and like depend on herd immunity? And how long do you think it will take for society to develop herd immunity?
Okay, so thank you, John. That's a great question as well. So let's just use the United States as an example. Maybe we could mute if we're not, that would be helpful. I hear a bit of an echo. 150 million people. So we know from other viruses, well, first of all, we know that nobody before a few months ago had any immunity to this virus. We were, all 350 million of us were susceptible. We had no prior immunity. So we know from other viruses like flu and from other infections like tuberculosis and other things that in general, to achieve herd immunity, it depends on the virus, but generally you have to get somewhere between 60 to 80% of the population to become immune to protect the remaining 20%. So you have to let 80% of the population get exposed to save the 20%. So if we did that in the United States, you can do the math. If I told you that conservatively 1%, just 1 out of 100 people, who get this infection are going to die. And they're all going to be, most of them will be older, but 1 out of 100. And you infect 300 million people. How many people are going to have to die to achieve that level of herd immunity? Millions, 2 to 3 million. So we could let herd immunity protect us. It will take a year or two, probably, for this just to tear the Band-Aid off and let the virus spread. But we would have not only 2 to 3 million deaths, conservatively, we'd probably have more than that. Why? Because we would overrun the hospitals, because it's not just the 2 million who die, because for every person who dies, there's another 10 who end up in the hospital and need an ICU bed. And so look what happened in New York with just a small percentage of the population getting sick. It overran the hospitals. Imagine increasing that burden tenfold. And you can see why it's not a good idea for us to wait for herd immunity. That would be my answer to that question.
Hi, so my name's Hannah and I'm from Fairfax, Virginia. And do you think the culture of China and Korea had any effect on how quickly they contained it?
Oh, I'm sure. I don't know much about the culture in China. I know I've worked in India for 40 years. I can talk about that. I don't know much about China or Korea. But I think culture has a lot to do with culture and one's own, how important it is. Because look, it's a burden on the whole society to quarantine and to follow these kind of strict, almost draconian, some people think draconian rules. But we're not just doing it for ourselves. We're doing it for our parents, grandparents, neighbors, teachers, co-workers, etc., and their parents and grandparents and aunts and uncles. And so if you have a culture that values others and values community more than individuals, then it doesn't surprise me that some of these guidelines are more easily adapted in some cultures versus others. We have a very we're all about individuality and independence in the United States, but of course there are many cultures within the United States, right? And I think there are places where this is better, this is going to be better accepted than others, in communities and families where it's better accepted than others. I think that certainly it's very interesting. If you look at Italy, I could see this coming. I was concerned about what was coming when I saw my friends in Italy were dealing with, because Italy is a very gregarious, it's an open society, family oriented, very social. And people early in this epidemic were just like we were in the United States. They said, "Oh, it's not a big deal. We're not going to change who we are." And within a matter of weeks, almost everybody was burying relatives. And so that changes how people think about these. What they never would have considered possible, it changes. I was on a call this morning with a colleague of mine who's a doctor at Hopkins, and he has family in Ecuador in South America. He showed me a list. He put up a slide that had a list of names. There must have been 40 or 50 names on this one slide. They were the names of doctors in Ecuador that had in the last 3 weeks had died of COVID. On this list included 7 people he graduated with from medical school. 7 of his friends have already died in 3 weeks. He's in his 30s, so that this is these are young doctors and nurses who are dying. And so when communities and societies are faced and cultures are faced with that, they change. I think they have to.
Hi, my name is Nyana Selene Xavier. I live in Chantilly, Virginia. Recently, I've been hearing a lot of people say that they don't believe this virus is natural, that it's man-made in the sense that it was cultured in labs as a biological weapon and then released out into the world. What do you think is the validity of such theories?
I don't see any evidence at all that that's happened, and there's plenty of evidence that nature could do this all by itself. Look, we've been predicting this sort of thing for 20 years with influenza, with other coronaviruses. We don't have to create, it's certainly possible with current technologies, but we don't need to. This is very likely to have occurred naturally, and it will continue to occur. This is what we know about the biology of coronaviruses and influenza viruses. This is what happens. So I don't have any evidence to suggest that it's anything other than what we've always expected, is a very unfortunate what we call zoonosis. Zoonosis means where viruses in animals that normally don't circulate in humans jump to humans. Virtually every outbreak of new viruses we've had in the last 100 years has been a zoonosis, from an animal virus jumping to humans. HIV came from primates. Influenza comes from birds and pigs and other animals, et cetera, and coronavirus as well. Ebola is another example. Marburg virus, they're all animal viruses that jump to humans when humans and animals mix. And I don't think we need you don't need a smart biologist to make that happen. Nature's unfortunately done that for us.
Hi there, I'm Marin, I'm from Maryland. So I was wondering, I've been hearing a little bit of buzz lately about like possibly infecting healthy like young people with the virus to try and speed up research on it. So do you think that the obvious ethical concerns of that outweigh the potential benefits?
I would never purposely expose anybody to this virus. I don't care what age they are. I don't think that's ethical. I mean, I'm not exactly sure what you're referring to, but we often talk about in vaccine development, something called challenge studies. So challenge studies would be where you take animals or people, you give them a vaccine, and then you challenge them with whatever you're trying to develop that vaccine against and see if it protects them. It's a way to kind of force the natural experiment that you might otherwise do, where you vaccinate people and let them go out into the community and see what happens. It can speed up the development, but there are major ethical problems with that. And that's not just true for coronaviruses. But this is a deadly virus. Why would I think you'd have a hard time justifying exposing even young people to a virus that has potential mortality like this.
Hi, my name's Nicole and I'm from West Virginia. I know the Spanish flu pandemic had a second wave after social distancing measures were relaxed. So I was wondering if it was possible that coronavirus could also have something like that occur.
Absolutely. Absolutely. Why wouldn't it? I think it very much will. Particularly if people don't follow through and pay attention to the social distancing. Because remember, it's all about how much of the population is still at risk, right? So there's some studies from New York that just came out today that suggest in certain communities about 10% of the population have evidence of antibody, might have been infected. That means 90% do not. Those 90% are risk for the next wave, and the next wave, and the next wave, until, as we've talked about with John V, the whole country's infected and then millions die. So we don't want that. We don't want to have these waves, but they're certainly going to happen, because if we don't do something about it. We're hoping that this first wave is over, or resolves itself, and the virus is not going to go away. It's worldwide. It's going to stay until we have a vaccine. So the key is to keep the levels down so it doesn't come back and roaring back in the fall or any other time. And I don't know if it's going to work. I don't know if we will be able to stop a second or third wave.
Hi, I'm Kavina, and I'm from Fairfax, Virginia, like Hannah. And kind of going off of Nicole's question, I was wondering, based off of like the current evidence and the current policies, how long do you think like physical distancing would be required? And also, as high schoolers, what do you think we can do to like help during this time?
Well, thanks, Kavina. Well, the best thing you can do is follow the rules. You guys have low risk of developing serious illness, but you're at high risk for sharing that, unintentionally sharing the virus with others. So, continuing to wear masks if you have to go out. I think The school situation is an interesting one. I guess a lot of you guys are getting ready to start college, and I'm sure it's stressful to figure out what's going to happen. I know Hopkins is trying to figure this. All the universities are trying to figure out what they're going to do in the fall. I'll tell you what might happen, might help. I think if we can get the prevalence in the community down to a low enough level, and we have enough testing out there, what we might see is something like the following, where college campuses and schools, it may be more difficult in elementary schools, but for older people, older students, I can envision a situation where to be able to get into a classroom, you have to swipe your badge, or to get into the cafeteria, you have to swipe your badge these days. That your badge, you're going to have to document that you had a negative COVID test last week in the last 7 days. And you might have to get swabbed every week or every couple of weeks just to maintain. And if you're positive, the campus health department can deal with that. Maybe quarantine you in your dorm for a little while, just as a way to keep it controlled. But you can envision perhaps something like that. But we need to have the testing available. And you can look. You have to prove that you've had measles vaccination before they let you on campus and live in a dorm. So we have a precedent for these sort of things. We just need the infrastructure and the systems in place to do it. I think it's doable. That's an example of something that might help, right? Open things up.
Hello, I'm Fiona Romanowski from Dallas, Texas. Relating to the previous question, you said that many things will change in relation to universities and things like that. With this current pandemic, many systematic problems have been exposed within our government and our public policy. How do you see the field of medicine itself changing after this pandemic?
That's a good question, Fiona. I think, as you've said, we're all going to change. We're all changing, not just medicine. I think one of the big challenges I see right now is that the way we practice medicine may be changing. For example, even before this, we were starting to shift towards a lot more telemedicine or remote medicine, where people could have their doctor's visits from home, for example. And for a lot of things, perhaps that's good. We're going to do more of that, right? And perhaps for a lot of things, that's probably okay, right? I mean, we have ways to monitor our blood pressure at home or our glucose at home. And I think we could leverage a lot more of that kind of approach. I think patients tend to like it too, right? People tend to like the fact that they don't have to come to a busy clinic or sit in a waiting room with other sick patients. They can get their blood work and other things done from home, maybe get an evaluation. We have to figure out in medicine is what types of things we can do for patients, what kind of care we can provide that makes sense. But we also have to hinge it on outcomes. So we have to show that we can take care of people and keep them healthy using these new approaches. And I'm not sure we know exactly what we can and can't do remotely for which patients. So another example, of course, I think is reflected in your question, is we have a lot of health disparities in this world and in this country. Not everybody's going to have a cell phone. Not everybody can afford telemedicine, the Wi-Fi that you need for telemedicine connectivity. Not everybody is going to have access to care. Not everybody is going to feel comfortable with that technology. And so we still have a lot of challenges there to see whether or not we can actually, when we transform how we do medicine, that we don't leave more people behind, because we already leave a lot of people behind in our current system. And so those are the things that I worry a little bit about. But I think, like everything else, we're going to have to change the way we do things. And in the beginning, it might be primarily things like what we do we describe with the campus situation. So this past week, Hopkins and other hospitals have decided that if you need a surgery, for example, urgent surgery, they're setting up same-day screening. So if you have to have your gallbladder removed, perhaps just like you have a blood test to make sure you're not anemic that day, you also get a swab to make sure you're negative before you come in the hospital, or you know, and that kind of thing will help. So there's some procedural things and practices that might change as well, Fiona. So, but I think I also think it's going to change. I hope it changes our understanding of how important public health is. You know, I'm a clinician. I still take care of patients at Hopkins, but I also now recognize how important it is for community nursing and for public health people to be able to, you know, be in the community and not necessarily have to wait for all care to be delivered in a facility, in a clinic or in a doctor's office. There's a lot more we can do to support people where they live, where they work, where they go to school. And I think a lot of other countries have done that for a long time, have strengthened their public health programs. And hopefully that's a step in the right direction. Does that answer your question, Fiona?
Yes, it does. Thank you very much.
You're welcome.
Hi, Professor. My name is Michael, and I'm from Toronto, Canada. I was just wondering, in light of the recent anti-lockdown protests, what do you think is the best way to convince people to observe social distancing?
Boy, that's a tough one, Mike, because I'm not sure that the people that are protesting that I've seen are convincible in many cases. I don't know what you could say to people like that that would convince them. I mean, I understand the frustrations and the challenges, and certainly, particularly, you know, the people I'm more concerned about are the people that want a social distance but can't because they're too poor or because they have to work. And you know, I'm sure there's some of those people that are protesting fall into that category. But you know, I guess, you know, perhaps this is a harsh analogy, but you know, are you familiar with with Russian roulette? I never know whether my metaphors are resonating at all with the current
Not from
high schools.
personal experience, but I'm familiar with the concept.
Good, good. So one way to think about this perhaps is that, you know, certainly, and maybe not in Canada, but certainly in the United States, we have this concept of individual rights and individual freedoms and so forth, which are important. To the extent that if somebody wanted to take a 6-gun and put a bullet in, spin the barrel and point it at their own head and pull the trigger, most people think that would be a really, really stupid thing to do and a dumb thing to do. But a lot of people might say, you know, it's up to them if they want to do that. If they want to be you have a right to be wrong. You have a right to be an idiot. However, now if you take that same gun, you put some extra bullets in it, you spin the barrel and you point it at your neighbor who might be an elderly person with diabetes, or you point it to a stranger on the bus, or your coworker, and you pull the trigger. Now it may not go off, but you've now increased the likelihood that not only is your stupidity or your lack of caring about others or yourself is now affecting other people. Now, I don't think most of us would think that, you know, most of us would figure if there really was somebody pointing a gun at somebody, spinning the barrel and pulling the trigger, that we would do something to stop that. So I don't know how far the analogy goes, obviously, but I'm not sure you can convince people to play Russian roulette with themselves. I'm not sure how you convince them to not do it, because if they're willing to point it at themselves, to me that says something about how difficult it will be to convince them to not pull the trigger, not play the game. I'm not sure if, Michael, that answers your question or not.
Oh, yeah, it does. Thank you.
Hi, my name's Steven. I'm from Washington State. My question is, do we expect that pandemics of this magnitude will happen in the near future? And if so, how often will they occur?
So I can answer the first question, well, the first question has 2 parts. Will they happen again, and will they happen in the near future? And I think the answer is, I think they will happen again, as long as we've had 3 coronavirus epidemics in the last 20 years. We'll have influenza epidemics. We'll have other zoonotic. We'll have other versions of Ebola and things like that. That's inevitable given how our society is structured, how we work, how we live. The question is whether we're going to have one like this or not. This is, you know, it's hard to predict that. I mean, but I have every, I mean, look, I'm not concerned that we're going to run out of a need for infectious disease in public health people. I think what I'd love to see is moving forward to reduce that risk is that we have more people who understand the importance of what we call One Health. One Health is some of you may already know, is a concept that talks about how important it is to integrate human health, animal health, and environmental health, and that they're all linked to each other. Hopefully, one of the things we can do is to get people more aware of and study the science of One Health to help us identify risks like this in the future and maybe mitigate those before they happen. So unfortunately, I think the answer, Stephen, is that yes, we're going to have them. I think we have to be prepared for them to happen, better prepared than we have been.
Thank you.
Good afternoon, Dr. Bollinger. My name is Momin Ahmed. I'm from Ponte Vedra, Florida. My question was, so recently the American government has put great emphasis on the drug hydrochloroquine, the anti-malarial drug. What is the sort of what do you know about the drug, and what have studies shown about its effect on coronavirus? Because there's much speculation, and I've heard in the news many people are overdosing on it because people are believing that it's a treatment. So
the drugs, there's two drugs out there that are cousins of each other. One is called chloroquine, and the other is hydroxychloroquine. Chloroquine is a drug that's not really available in the United States, but used around the world to treat malaria. And then there's hydroxychloroquine, which is cousin, which is also used to treat malaria, but in the United States, we use it to treat certain forms of arthritis. But overseas, in India and other places, hydroxychloroquine is ubiquitous and often used to treat malaria. So we know a lot about the drug for malaria and for things like lupus and rheumatoid arthritis. The data on its, to be honest, I don't understand why it's gotten so much hype, because the data does not suggest to me that it has any efficacy or likely to have any efficacy in treating or preventing this infection. There have been some studies where you take this drug and you throw it into a laboratory culture medium where you grow viruses, and you stick that drug in there, and the viruses don't grow as well. But you could put anything in, you can put virtually anything into a culture medium and stop viruses from growing, but it doesn't mean it's going to work in human beings in the same way it works in the laboratory. And so a lot of people have extrapolated data from laboratory studies in test tubes to think it's going to work in humans. There are some studies right now. The way we determine this, the right way to do this is what we call randomized clinical trials, where you say, okay, this looks like it might work in animals or in the test tube. Let's first make sure it doesn't make people sick, and let's see if it works. And the best way to do that is you take a group who might need it, you give half the new drug and half a placebo, and you find out whether it works and whether it makes them sick or better. That's the way to do it. And those studies are just now getting done. The preliminary studies analysis that have been done aren't, we call randomized studies, but those data, and a big study just came out a couple of days ago from a big VA analysis that showed that when you compare people who took hydroxychloroquine to those who didn't, there was no benefit in, these are coronavirus patients, there was no clinical benefit. In fact, more of them died in the group that got hydroxychloroquine than who didn't. And so I'm skeptical about this. I'm much more optimistic about the drug I talked about earlier and the serum treatment, because we have experience with those. Remdesivir has been given to other humans for Ebola. It had a little bit of efficacy. We know the safety profile, and we know, that's designed to block an enzyme that the virus uses to replicate itself. So it has what we call biological plausibility. We don't have any of that with hydroxychloroquine or chloroquine. I think you're going to find pretty quickly that ship has sailed. Although a lot of people are taking it, a lot of our patients now, even at Hopkins, come in there because their community doctors have read the same, watch the same news show, and they're giving, or people are insisting on. We've had some patients who threatened to leave the hospital who are really sick unless they could get their hydroxychloroquine, even though there's no evidence it works. And in some patients, it actually makes them worse because it can cause heart problems in people who have heart disease.
My name is Adam Zafrani. I'm from New York City. And do you think this disease could become a seasonal illness similar to the flu and perhaps even mutate every year?
That's a good question. It is mutating already, Adam. Whether it's mutating enough to require, whether it's mutating enough to mean that people who have immunity today will get infected again next year, I don't think we know the answer to that yet. As I mentioned earlier, for the other 4 coronaviruses that are cousins of this virus, now they're not close cousins because they're only about 60 to 70% identical to these genomes, but they're cousins. We know people can get reinfected with the same coronavirus and that the immunity on average lasts a year or 2. But if we have the systems in place to develop a new vaccine for the new strains, we could do it. We do it for flu every year, right? We know how to do that. So if we needed a new vaccine, if we could find one that worked, and we needed to revise it every year or 2, we could do that. We do it already. So we have the science, we have the infrastructure to do it. We just have to learn more about the immunity. So yeah, it's possible it could mutate, Adam, but I'm confident that if we figure out how to make the first vaccine and make that effective, we'll figure out how to modify it if necessary, like we do with flu. And look, I'd rather get a shot every year. I get my flu shot every year. I'm happy to add my coronavirus shot every year, if that would help.
Hello, my name is Tara, and like Adam, I'm from New York City. Would the people who refuse to take the vaccines for flu also not take the vaccine for the coronavirus, or will they be mandated to?
It depends on where you live as far as their mandate. So I think, look, there are people that don't take their measles vaccines, even the people that don't take any vaccines, and I'm not sure. I'd put them in the same category of people that don't care about social distancing when their relatives are at risk for dying. So so there are always going to be people like that. I don't know that you can mandate that in our society, but you might be able to mandate it. It may be mandated in other societies and other cultures around the world. But we generally don't force people to get an injection for any reason. We do things like make sure that you have your smallpox vaccination or your measles vaccination before you leave school. We can do that. We can make sure that as a physician or a nurse or a doctor at Hopkins, I have to have a skin test every year to make sure I don't have tuberculosis. Otherwise, they don't let me come to work. So we have some strategies carrot and stick of strategies to help, increase the uptake of vaccine. I think it'll be difficult. What do you think, Tara? Do you think we could mandate or force people to do it?
No, I don't think so, because I think some people would say it would violate their constitutional rights, even if it's for the benefit of everyone.
Yeah, I think you're right.
Hello, I'm TJ and I'm from Kansas. And just piggybacking off of that same question, I'm seeing a lot of correlation between politics and a community's ability to actually meet healthcare standards. So like African Americans or Hispanics' ability to actually social distance. So my question is, from what you've experienced, how can the needs of healthcare actually impact politics, if it's possible at all?
Boy, that's a really important question, TJ. I want to turn it back to you a little bit and ask you to maybe refine your question a little bit more specifically. Give me an example of what you're worried about.
Right. For an example, just policy wise, and I'm going to just relate it back to like just like racial disparities in like economics. African Americans are least likely to actually have jobs that will allow them to work at home rather than having to go outside, especially with many Hispanic people in the nation. So I'm just wondering how the needs of like healthcare, the needs of the people can actually cause politicians to change policies to help these certain communities.
Boy, it's such an important question, TJ. And that's a great example that illustrates what we were alluding to earlier about the, about how health disparities can not only affect your risk for diseases, but your ability to protect yourself from diseases, right? And limits your choices, not only to protect yourself, but your own family, right? Or your own neighbors. This epidemic has, I think, it just shines a light on what we already know about these health disparities more broadly. And so I'd like to think that that bright light leads to enlightenment and change. But I'm a little cynical about that, to be honest with you, TJ. I think it's going to require more than just a bright light. It's going to require mobilization. It's going to require it's going to reflect how people vote, who they vote for, what we ask our politicians to do for us. I think that's how change is going to occur politically. It's about the ballot box. And if enough people understand what you're describing and how important it is, and can translate that knowledge and that interest into changing our politicians, then maybe the policies themselves will change. But I guess it depends on where we live and how hard we all work on some of these things, and how important, not just the people that are affected, not just the people who are disproportionately affected by this. But look, we've had similar issues with disparities in education and disparities in jobs, disparities in economic opportunities. All are related to the same disparities in health. And they don't change unless the politicians change. So I think we change them, and maybe we can change the policy. I'm not sure if that helps, TJ.
I just have one question, like one follow-up question. For someone who's thinking about getting a job in public health, is it really possible to actually create like a modicum of change rather than like relying on politics or politicians?
Yeah, I think, look, and that's true, not just in public health, but in anything we do, right? Look, you can be as frustrated as a lawyer or a doctor or a public health official or a firefighter. I can only tell you from my own personal experience as somebody who does both clinical work and public health work, I get frustrated with some of this stuff too, not just here in the United States, but I work in other countries where these same issues come up. And I have to tell you, I personally get my gratification when it gets really tough and I get really frustrated with the politics. I focus on what I can do today for the person in front of me. So if I'm caring for somebody that has tuberculosis or a family that's at risk for COVID, I do my best to help them. And I'm in a unique position oftentimes to be able to help them. When I go home, I think about all the thems I had to deal with and help, and I get frustrated. But I don't lose hope, because the next day I go back in and I have an opportunity to help another family or another person. And so you balance the gratification and challenges you get from helping individuals with the frustration sometimes of getting a system to change. I don't think it's unique to public health. I think it happens in lots of different careers. But I think what also happens in public health is that we begin to, we have an opportunity to educate the public as best we can. Now, we're not always going to educate the people, as we talked about, who aren't going to listen. But there are many people that will listen if they're given the right information and the right education. And I think a public health care is an opportunity to be an educator as well. And that's where I think you can change policy. You know, I'm also a researcher. I'm a public health researcher. And in my world, I've often told people that I think it's perfectly possible to live a faith-based life and make evidence-based decisions. And so I'm all about evidence and collecting data and research data and figuring out a way to present that evidence to people in a way that helps help them make informed decisions. And that's another thing that public health people can do to change policy, is to provide data and provide evidence that people can use, because information can help. I'm trying to be both optimistic and realistic with my answer at the same time, TJ.
Thank you for your answers.
Hi, I'm Nikita from Pennsylvania, and you mentioned before that the reason why the coronavirus is more worrisome than the flu is because it's more infectious. Why is it that the coronavirus is more infectious than the flu?
It's not just more infectious than the flu, it's more worrisome because it's more deadly than the flu. So there are two related issues. So we think it's more infectious because that spike that I showed you a picture of in the first slide is stickier than the influenza spike. It sticks to our cells more tightly. And so because of that, it's able to spread itself and infect more people because it has a stickier spike, for lack of a better metaphor. The reason it's probably also the reason why it's more dangerous, because it can work its way. Most coronaviruses just stay up in our nose and in our throat, give us a sore throat and a runny nose. And if that's all that happened, we'd be fine with it. But this thing works its way down into the deeper part of our lungs and causes pneumonia. And it does that more easily than the regular influenza seems to. I mean, regular influenza can cause the same problem. We have 20, 30,000 people every year in the United States who die of regular influenza. And it would be even worse if we didn't have people getting vaccinated. But this particular virus has a mutation in its, we call the spike, or the S1, S2 protein, that allows it to be stickier. And that's why we think it's both more infectious and more dangerous.
Thank you.
You're welcome.
Hi, my name is Julia and I'm from Maryland. And my question was, how are you able to treat people with severe health issues that are unrelated to COVID-19 if they're emergent and you don't necessarily have time to test?
So I'm not quite sure, Julie, if I understood the question exactly, but are you asking how do we care for people who have, for example, a heart attack in an emergency where there's also COVID?
Yes, if you don't necessarily have time to test for them and wait for that test to come back.
Well, right now what we're doing is if people have any symptoms at all, or they've been exposed to somebody in their household, we do what's called triage them. We move them to a specific place in the emergency room and care for them there. That's away from patients, from other types of patients. And so we hopefully are able to reduce the risk of mixing people that might have COVID with those who might not. But that's the best we can do at the moment. And that's one of the reasons why a lot of health workers are getting infected, because we get it right most of the time, but sometimes we don't. And we have people that have no symptoms. They came in for a heart attack and we didn't know it, but they had COVID and they just exposed everybody in that part of the emergency room.
Hi, my name is Ria and I'm from Pennsylvania. And I was wondering, in your opinion, once this pandemic ends, however long that might be, what do you think should be some of the first steps we take as a global community to prevent or be better prepared for a future pandemic?
Oh boy, Ria, um, that's a really tough one. It's an important question. Let's see. If I were Bill Gates, what would I do with all my money to prevent this from happening again? Look, I think I would certainly do some of the things we've already talked about. I would invest in public health. I would invest in making sure we have people in the community working on issues like this, working on flu, working on influenza, working in One Health, to basically be out there detecting these problems early so we can address them more quickly. And that's the second piece. So it's all about detecting problems sooner and potential problems sooner. So how do we do that? We need to get people and infrastructure in place to make sure that we're screening for new infections, for example, in animals and humans when they interact. And we're identifying potential problems sooner before they spread. The other is then the response. So what do we, so do we have systems in place that allow us to respond more quickly to, for example, quarantine? Do we have enough PPE? Can we scale up hospitals more quickly so that we can respond more quickly than we have now, more effectively? Can we develop vaccines more quickly? Can we come up with strategies that will be ready to go? So platforms that could be such that, you know, the next coronavirus, as I think it was Adam, I think, who asked about if the virus changes, could we just slip that new gene into the old viral vector and make a new vaccine really fast instead of waiting 18 months? There's some scientific investments we could make. But I think the other thing is something I think TJ alluded to, is that we have to understand that as long as we have health disparities as stark as we do, we're always going to have these issues. And we don't have to wait for the next epidemic of coronavirus to start dealing with those. And if we reduce those health disparities, the impact of the next coronavirus will be very different for all of us. And so I think there's a lot we could be doing, not just to prepare for the next coronavirus pandemic, but much more we could do to protect and support and address some of the populations at greatest risk and support their health in general that we're currently not doing. And I think we could do a lot more there. And that would really be, I mean, I think that's where if I was Bill Gates, that's where I would put my money. And I hire more people like all of you to do it.
Hi, Dr. Bollinger. My name is Adi, and I'm also from Pennsylvania. And I was wondering what your thoughts are on the whole door-to-door testing in the US, and if it would be viable and effective like it was in China, as you mentioned.
Thanks, Adi. So I was talking to people today in India about the same thing in India, the same question in India. And I was talking to people in San Antonio last week about the same issue, same question. So this is not unique to any community. And it's very interesting. I got many of the same concerns raised that I expected to hear from all these different communities about door-to-door tracing. So in India right now, if you are found to be positive, if you get a swab and you're found to be positive, do you know what happens?
I'm not sure.
Well, in India and many other countries, the police arrive at your house and you're taken into the hospital. Your whole family is quarantined. There's a big police cordon that goes around you and the neighborhood. Everybody in the neighborhood knows your family's a COVID patient. If you happen to work in a hospital that's seeing COVID patients and you're a nurse or a doctor, sometimes you're even thrown out of your apartment because they don't want you. This happened in New York. You probably heard about there were nurses and doctors who were basically told they should get out of their apartments because people were worried they're going to bring COVID back to housing. It's a real concern, right? I mean, I've already told you that's how it spreads. But the stigma that's attached with being diagnosed is this very similar to the stigma that we have with leprosy. I worked in leprosy 40 years ago, or HIV. That's preventing a lot of people from not only accepting door-to-door screening, but even coming into the hospital when they're sick and they should be tested. If you're undocumented, if you feel marginalized in any other way, if you're unwilling to come into the hospital, I'm not sure you'd be willing to have somebody knocking on your door. So there's a lot of, one of the most important things we have to do in public health is learn how to communicate and build trust. It's not easy, but without that trust, I think door-to-door testing is going to be difficult. And it's certainly in practice, and it's possible to do it, but whether we're able to do it, I think is going to require much more than just more tests. It's going to require, maybe, as TJ said, changes in politicians who are promoting policies and communications and programs that people can trust and not feel stigmatized by, threatened by. I mean, we're deporting people to other countries who have COVID infection right now. So we just sent people to Haiti, deported people to Haiti, some of whom were positive. So how likely is that kind of strategy going to encourage people to accept door-to-door screening and contact tracing? I'm afraid I'm giving too much bad news. Can somebody ask me a happy question, please?
I have a question following up on that. This is Nikita again, by the way. How do you think we can destigmatize like coronavirus and make people not as freaked out about people having it?
Well, I think there are two things that we can think about. Number one is we've learned a lot from other diseases like HIV. And that's what we call universal testing. So if you just offer HIV testing to everybody, no matter who they are, without any distinction, you don't say, okay, we're only going to offer HIV testing to people that look like they're left-handed. So we're going to offer it to right-handed and left-handed people. We're not going to care whether you're right-handed or left. We're going to offer it to young, old, every type of person, male, female, etc. So universally offering services, I think, is one way to overcome stigma. Because, and also I think you have to offer a benefit for the screening. For example, I mean, if I offer everybody in a community testing, but only some of them are allowed to come to get treatment, or only some of them are allowed to get social services support if they need to be quarantined or get food deliveries, then what's the point of the screening and the testing? So I think we have to offer universal services as well as universal testing to reduce stigma. I think the other thing is that well, I think that's the main thing. We have to offer everybody the benefits, not just the risk of being tested and screened to reduce the stigma. Does that make sense?
Yeah, thank you.
Hi, this is Steven again from Washington State. Do you think it's okay for certain areas of the country to open up already because they're worried about the economic ramifications when the health issue isn't fully solved yet?
I think it really depends on where they are. I mean, this is a tough question for all the communities, right? Look, the quarantine does not have it's not a one-sided sword, right? Communities, are suffering. People are getting sick for other reasons because they're being quarantined. In India, people are at risk for starving because of quarantine right now. So in the United States, people aren't able to work and so they're going to end up getting, there'll be increasing rates of suicide or of chronic disease complications over time. So there's got to be a balance between the risk of opening up and the risks of not opening up. And I think that calculus is at this point tough to do because we don't exactly have enough data to make decisions. I think what we're going to see is communities are going to try stuff like this. Some are going to open up sooner than others. As we go forward, we're going to learn what's working, when and where, and what doesn't work. And hopefully we'll learn from each other what strategies make sense are going to work. But we're all kind of shooting in the dark here right now. I think it makes sense to me to at least wait for the trajectories to be going down before you start to begin gradually to open up. And you're not going to just flip a switch and just all of a sudden have NCAA football games again. I'm sorry to say, but it's going to have to be gradually rolled out. And I think some communities are going to do this more quickly than others and in different ways. We're going to learn a lot of hope from what happens in Europe. We're going to learn a lot from what people in Nebraska do versus what people in Texas versus Baltimore. And we'll figure that out. Hopefully learn from each other.
Thank you.
Hi, it's Nicole again from West Virginia. I was wondering, why are some people asymptomatic and then some other people will pass away in maybe a week after getting the virus? What determines that kind of thing?
Well, I wish we knew that answer to that, Nicole. We don't know yet. We certainly know that the older you are, the more likely you are to have severe disease. So it suggests that as we get older, our immune system changes, right? So perhaps there's some underlying issues around how able we are as people to fight off infections that determine how sick we're going to get. We know that men are more risk of getting severe disease than women. We know that, as we've talked about, there's certain communities at greater risk. African American, Latino communities are at greater risk for more severe disease. A lot of that, as we talked about, is related to the risk of what we call comorbidities, or they're also at risk for underlying other health conditions like lung disease and smoking and hypertension and diabetes that could be increasing the risk of more severe disease. But we're still learning about some of those things, and we don't quite have all the answers yet. Yeah.
All right, thank you, doctor.
You're welcome.
Hi, I'm Isha. I'm from Pennsylvania. I was wondering what the logic would be behind deporting someone with the virus, because wouldn't that just spread it to another country that may not be as severe as the United States?
Well, Isha, I hope I didn't say that I thought it was logical. And if I implied that it was logical, I didn't certainly mean to imply that, because I don't think it's logical at all for all sorts, or ethical for all sorts of reasons. But yeah, it doesn't make much sense. I mean, if you start deporting people who are positive, what is that going to do to incentivize testing? I'll give you an analogy. So there were many years, I've been involved in HIV work for many decades. There was a period of time before all of you were born where there was Illinois and Indiana, the two adjoining states, where in one state it was mandatory that you have a HIV test before you could get a marriage license. I think it was in Indiana, but it wasn't mandatory in Illinois. So what do you think happened?
The marriage rate dropped in the state where it was mandatory?
They all moved to Illinois to get married, but they didn't get more HIV testing. So people were disincentivized to get HIV testing. So if you start deporting people, or you treat them badly, or you don't give them services if they're coronavirus positive, that's the worst thing you can do in public health, because that just disincentivizes testing.
Hi, it's Tanvi again from St. Louis. One of the things you mentioned a bit earlier was about some of the gender/sex differences in morbidity. So I've read that morbidity for men can be up to double in certain areas than women. So do you think that is, like a hormonal, like there's a hormonal aspect of this disease, or like differences in immune system, or what do you think causes that, sex difference in the morbidity of the disease?
So again, great question. I'm not sure we have the answer to that, but people have speculated, like you said, it could be because men are more likely to have comorbid diseases. We are. We have more bad habits in lots of ways as a gender in general. I'm not speaking specifically about anybody. But there also are immunologic differences between men and women. There are other infections that are more or less common in women and men that we think has to do with differences in biology of some sort. But we're not entirely clear what those are or whether they're actually important.
Hi, Dr. Bollinger. My name's Lauren, and I'm from Maryland. And I was just wondering, how have surgical procedures changed during this time?
Well, they've stopped unless they're absolutely emergent. Unless there are absolutely emergency procedures are not being done. And even when they are being done, they're now, as I said, we're doing screening of people before the surgery. And I think eventually we'll start doing, more urgent stuff and not just, delaying everything. But it's going to be a while before we're going to be back to doing what we call elective surgical procedures, things that can wait for a month or two. Get your mole taken off or get your cataracts done, that kind of thing. Unfortunately, we're going to continue to delay those things. It's a bad time to be an ophthalmologist.
Hi, so my name's Hannah, and I asked a question earlier, and I have another one actually. So do you think as this pandemic continues, we will face the chance that we have a slowly depleting community of medical professionals?
I don't think so. I'm hoping that the opposite's going to happen. I think that a whole new generation of people are going to get much more interested in public health, One Health, medical profession. And I think historically that's what happens. When we have challenges in history, I think in general, people don't run away from it. They step up. And, the people that I know that are in the medical profession in general are the kind of people that are used to stepping up. And not too many of them are going to run away. There are some that are going to be, and many who are always going to be concerned about their own health and particularly the health of their families and patients. I have a son who's an EMT in Chicago, and he's on the front lines every day, and his main concern is getting infected, not for himself, but he takes older people back and forth to the hospital every day. He doesn't want to infect his patients, and so I think. Talking to him and talking to his colleagues, there's not a lot of people looking to run. People are running towards to help the problem in general, most of them.
All right, thank you so much.
Hi, my name is Abigail Bridgman. I'm from Columbia, Missouri. So obviously in the US, a first world country, we've seen a lot of struggles with obtaining personal protective equipment for our healthcare officials. And so I was wondering, as COVID-19 is spreading to more developing countries with fragile healthcare systems that are possibly struggling to obtain like basic supplies that we have here in the US, how do you believe that the COVID timeline is going to change? And also, what kind of concerns do you have for that kind of situation?
I'm really worried. I have not just for so many reasons that you've talked about. I think I have a lot more experience in India. I know India, and I work a lot in parts of Africa, particularly in Uganda, Ethiopia. So I can speak, more specifically there about the situation in those kinds of places. But I have a lot of concern about the impact and the lack of resources. I mean, there are places, I work with one of the largest. There are 5 medical schools in Uganda, and one of the largest, Makerere University. It's one of the largest hospitals in sub-Saharan Africa. I think they have 10 ventilators for the whole country. So you can imagine what that means for a society like that or a region like that. So not just lack of PPEs, but the lacks of oxygen tanks. It's a huge problem. and a huge challenge. I think I was talking to my friends in India this morning about this, and one of them said to me, the one thing that we're thinking about and sort of challenged by is that only 15%, no, I think it's less than that, 10% of the population in the state of Punjab is over the age of 65. So they're saying, well, wait a minute, we're going to get a lot of people sick, but how many are really going to overrun our emergency rooms and our ICUs? Because we don't have that many people over the age of 65. So I was listening to that, and as a public health person, my reaction is, well, why aren't people living past 65, right? Why are so many people dying young? But that's the kind of calculus that some of these countries are having to think about. Is it, should we put resources into preparing for more ICUs when only 10% of the population is over 65? Should we let that go and accept the fact that people are going to die at a really high rate? Should we focus on the other younger people and resources for that? I mean, these are tough decisions these countries are going to have to face.
And then just a follow-up question, do you think the spikes in these more developing countries, do you think they're possibly going to be more severe and worse?
In other countries?
Yes.
Well, I think it could be. I think eventually, again, it may have to do with the age of the population, right? Because if you look at, two examples might be South Korea and Italy, for example. So South Korea had far fewer deaths than Italy, but Italy's average age is one of the oldest in the world. So, it may be that that the spike is going to be a different kind of spike in some of these countries in sub-Saharan Africa, where the average ages are much lower. But on the other hand, look, there are chronic diseases in younger people in many of these same communities. I pointed out to my friends in India this morning that, India may have a relatively young population, but they have more diabetics than any other country in the world. They just happen to be younger. So what does that mean as far as the spike is concerned? So I think we're going to see a spike. It may be delayed a bit, but eventually it's going to, this virus is too infectious. It's not going to go away. There's nothing about being from, a particular country that's going to necessarily protect you from this. We have to protect ourselves and each other from this.
Thank you.
Well, listen, I have to wrap up. We have time for another question or two. Who hasn't had a chance to shout out where they're from?
Hi, I have a question. I'm Avi from Pennsylvania, and I was wondering what else we could do as people in the society to help keep ourselves and other people around us safe from COVID, while also other than social distancing. What else can we do to help keep ourselves safe?
So, Avi, do you have any friends, relatives who are not practicing social distancing?
No.
Do you have any friends or relatives or neighbors who are unable to practice social distancing because they have to go to work, they have to work jobs that don't allow them to stay home?
No. Most everyone I know is working remotely right now.
How about in your broader community, not just your local neighborhood? And are there organizations that are providing support to people who have to go to work? So the reason I'm asking you this is I think there are probably opportunities in all of our communities to contribute, not just to protect ourselves, community, but also to support people that have to go to work or that have to go out on the front lines. Even something as simple as providing them a meal so they don't have to cook for themselves, or providing people groceries delivered so they don't have to go out and get them. If they're unable to do that. I mean, not everybody has Instacart, right, where they can get food delivered. So you know, there are plenty of things that we could do both at an individual and community level to help. And I would encourage all of us to think about that.
All right, thank you.
You're welcome. Any other, Ryan, are you the last?
Hi, my name's Emily Guerrero, and I'm from Munster, Indiana. And I guess like to kind of end on like a more optimistic note, like you said that the United States is like plateauing, and so that could like mean to like a decrease in cases. So could like the United States like see like things going back to normal by like the fall, or is it still gonna be increasing in cases?
Let's define normal, Emily. I'm not sure we're going to ever go back to normal after this. There'll be a new normal. We'll get there eventually, and all of you on this call will be part of that new normal. And I think you'll also be part of what defines what the new normal is. And I think our ability to be able to socialize again, go back to school, go to work, is going to depend on our ability to take the right smart steps instead of just tearing the Band-Aid off. And I think as we said earlier, we have to listen and learn from each other, from different communities, about what works and what doesn't work, and not do anything dumb. And I think if we open up certain societies' strategies and we find it's not working, we have to be willing to step back. So we want to take maybe 2 steps forward, but 1 step back, 2 steps forward, 1 step back, instead of pulling the Band-Aid off and having to take 5 steps backwards and start all over again. So I don't know if that answered your question, Emily, or not, but that would be my thoughts. Ryan, I think you were the last. Did you raise your hand, or did you have a chance to?
So I was going to ask, my name is Ryan Hanan, and I was going to ask, so we noticed that the pandemic originated in China earlier. So what particular actions in China do you think led to the disease? Because I've heard that it's because they eat animals, and I don't think that's true or not, but what's your perspective on that issue?
Thanks, Ryan. I don't know whether it's eating animals or not, but it's the intersection of animals and humans, either in the markets or in farms, that puts us in contact with animal viruses. So whenever humans get in physical or other contact with animal viruses, that's where the risk occurs. And then some of these, what they call wet markets, live animals were being sold, and some of them were infected with some of these viruses. And so there's certainly things, and I think the Chinese government is certainly, from what I understand, cracking down on some of this now. But I mean, there's certain kinds of agricultural practices, for example, where you have farms that raise chickens and pigs in the same environment. And so the pig viruses and the chicken viruses can co-circulate. Pretty soon you have combinations that end up with a new bird flu or a new swine flu that's more infectious. And so there are certainly things like that have been apparently challenges and issues in the past in places like China. But I think hopefully, look, a lot of people died in China from this, and their economy is getting devastated. So I would hope they're doing something about trying to reduce those risks going forward. I think we have one more hand raised. I'll have time for Sophia.
Hello, my name is Sophia, and I'm from Fairfax County, Virginia. And so I was just wondering if you can comment on how this virus compares to other viruses in terms of both seasonality and how it behaves, with the seasons. And secondly, in terms of immunity and whether or not you can be reinfected after having the virus. Thank you.
Thanks, Sophia. The first question is, we haven't had any seasons yet, so I don't know if it's seasonal because we've only had one season. So, let's have to wait 6 or 12 months to be able to tell you whether it's going to be seasonal. But if viruses, I'd expect it to be seasonal, or at least have ups and downs. We talked a little bit about whether you get reinfected or not. We don't know for sure. I suspect we have some partial immunity. I think if it was really easy to get reinfected, it never would have stopped or slowed down in China. remember what I told you they did? They took everybody who was infected and they put them in hotels, close to close, living in separate hotels with each other for weeks. Now, if this virus were easy to reinfect, you would expect that that would have actually compounded the problem, right? But instead, the virus died out in those communities. So some degree of immunity is probably happening, and I think the risk of reinfection, at least right after you're infected, is low. But whether you wait a year or you wait 2 years and your immunity goes down and you can get reinfected, we have to wait and see. Well, listen, I have to apologize. It's been great talking to everybody. Great questions. It was a lot of fun, interesting. I learned a lot. I hope you enjoyed it.